Thank you, Sushmita, for having me in this IC. So can OCT distinguish between glaucomatous and non-glaucomatous optic disease? So the differentiation can be difficult, especially in clinical practice, and optic nerve pallor is often used in discerning glaucomatous versus non-glaucomatous optic neuropathy. However, the identification of pallor is often variable and dependent upon the clinical experience. So the pattern of RNFL loss, macular GCC, and ONH topography findings on OCT scans may provide clues on DD of these optic neuropathies. So these are the common neuropathies which can mimic glaucoma on OCT: ischemic optic neuropathy, neuritis, compressive optic neuropathies, etc. So coming to AION, which is the most common optic neuropathy and the second most common cause of permanent optic nerve head visual loss in adult glaucoma. As we know, in acute stages, there can be optic disc edema and optic disc pallor in the later stages. And most often it is associated with small optic nerve head and no cupping and the altitudinal type of visual field defects. So these findings can also be seen on OCT if you carefully look at the OCT picture. As you can see here, in this particular eye, there is in the left eye, there is no cup at all. And in the right eye also the cup is very small. And there is a diffuse RNFL loss which doesn't correlate with the optic disc cupping. So as we know, AION is more common in crowded discs. So this finding correlates well with the disc findings. And similarly, it affects macula more, so that you will get asymmetric loss in two eyes, especially if the disease is there in one eye. So the OCT can definitely give some clues. In AION also, there are small discs and the pallor is there in the superior half of the disc, which correlates with the inferior changes in the visual fields. And you can see the macular changes in the inferior quadrant as well. So the differentiating points on OCT are that the RNFL thickness map shows diffuse RNFL loss, which is not same as glaucoma. In glaucoma, we'll get superior and inferior quadrant losses, and CTR is not consistent with the amount of RNFL loss. And in glaucoma, often the CTR is consistent with the amount of RNFL loss. So the lack of concordance between the degree of cupping and RNFL loss and visual field defect should be helpful in differentiating these two disorders. Again, in optic neuritis, there is acute optic neuritis, there is severe disc edema. That time it may not be possible to take the OCT picture, but sometimes if the visual acuity is good enough, then you see this very thick RNFL because of the edema of the optic nerve. So you will see exceptionally high values in the RNFL, as you can see here in the left eye, which is beyond the normal limits. And you can see the CD ratio. Again, the cup is very, very small or absent. There's no cup here. And the RNFL thickness is very high. So after a few years, after the attack resolves, you will see the damage in the temporal, especially in the temporal quadrant, as you can see here. So in glaucoma, the damage is in the superior and inferior quadrants, whereas in these disorders, the damage is in the temporal quadrant. And the damage can be more diffuse as well. So this is another patient. As you can see, 3 years after the attack of optic neuritis, the left eye shows significant damage in the temporal quadrant. Again, and cupping is not consistent with the damage here. And this is the first clue for the non-glaucomatous optic RNFL loss. And the second clue is, of course, that there is a temporal quadrant loss rather than superior and inferior. And if you look at the RNFL thickness map of the right eye, you can see this wedge-shaped defect here, again, which is suggestive of past attack of optic neuritis. Although there is no damage as such, there is just a temporal wedge defect. So again, any defect which is on the temporal side is suggestive of non-glaucomatous optic nerve damage. And you can do guided progression analysis also, and you can see there is a sudden loss in the RNFL thickness over a period of time. In a period of just 8 months, there is remarkable loss of RNFL here from 105 to 59. So very fast RNFL damage as the nerve atrophies over a period of time. So again, RNFL loss in the temporal quadrant, CDR not consistent. So these are the major points that CDR is not consistent with the amount of RNFL loss, and highest loss in the temporal quadrant. And the temporal parallel, of course, the clinical evaluation is necessary. Now this, the patient with hereditary optic atrophy. So basically here it is a bilateral condition, and you will get centrocecal scotoma in the visual field and the temporal pallor with temporal RNFL defects, as you can see here in the optic nerve head pictures, and also in the OCT there's temporal damage here and thinning of macular ganglion cell complex. This is nutritional optic neuropathy. Again, the patient who came to us as this suspect with slight temporal pallor, and there's no history of trauma, no positive family history of glaucoma. The IOPs were normal, and there were these definite RNFL defects here on the temporal side. And there were low serum B12 levels suggestive of nutritional optic neuropathy. Now coming to very important compressive optic neuropathy, which is an important cause of monocular visual loss. And the intraorbital and intracanalicular compressive lesions, they cause monocular visual loss. There can be presence of afferent pupillary defect, and there will be central or diffuse visual field defect depending upon the location of compression. So the RNFL, of course, is thinned out. And the clinical history and radiological investigations are very, very important. Here you can see this lesion which is extending into the optic canal, causing compression of the optic nerve and optic atrophy. Again, the cup will be very shallow with the temporal pallor. So, extent of RNFL loss and thinning depends on the anatomy of the lesion, and absence of RNFL loss in the fellow eye is very, very specific for this. So high asymmetry between RNFL measurements of the two eyes, because these compressive lesions are mostly monocular. So cause of monocular visual loss or RNFL loss, and especially in patients who are diagnosed as normal tension glaucoma. And if the glaucoma is progressing in one eye with normal pressure, it's very important to check for any compressive lesions. So in this particular patient, he was diagnosed as a normal tension glaucoma. The CD ratio was also high in this particular patient, but as you notice, there's no inferior RNFL damage here, which should be there in case of glaucoma. And there is absence of RNFL loss in the other eye. And so there is a high asymmetry between the RNFL measurements of both the eyes, which is an alarming sign for non-glaucomatous optic neuropathy, especially in patients with normal tension glaucoma. Again, in macular GCC, only one eye is involved, the other eye is absolutely normal. So again, this is alarming, and a patient with normal tension glaucoma with normal pressures and unilateral, especially unilateral glaucoma, should be investigated for any compressive lesions. So apart from OCT, there are other differentiating features between glaucomatous and non-glaucomatous optic neuropathy. Non-glaucomatous optic neuropathy is more common in young age. Pallor is more common. Then they mostly involve papillomacular bundle, and therefore temporal loss is more common as opposed to superior and inferior loss in case of glaucomatous. And they respect most of these conditions, especially the compressive lesion, they respect vertical meridian, whereas NION and they cause altitudinal defects. They are usually unilateral, especially in exceptionally in hereditary optic neuropathy and few congenital disc anomaly. And you require to do other investigations, and they may be associated with other factors like vasculopathy, nutritional and systemic diseases. So to summarize, as we know, glaucoma in patients, they follow the fields, and OCT, they follow this horizontal meridian. So this is the horizontal raphe, which is seen in glaucoma patients. The neurological disorders respects vertical meridian, and the AION and other lesions, the ischemic disorders can cause a diffuse loss of RNFL. So the degree of ONH cupping is generally disproportionate to the extent of RNFL damage. Significant pallor is there in non-glaucomatous, and pattern of RNFL loss can be different in non-glaucomatous optic neuropathies compared to glaucoma. Macular OCT shows vertically oriented thinning. However, in presence of typical RNFL loss and glaucomatous cupping, non-glaucomatous neuropathies must be ruled out, especially in cases, as I said, with a diagnosis of NTG and a comprehensive evaluation including visual field, visual acuity, color vision, and pupillary light reflex are very, very helpful in differential diagnosis, and of course, radiological imaging if you're suspecting a compressive lesion. Thank you very much.